Welcome everyone to the International Society of Cannabis Pharmacists. This is our next State of Cannabis series, my home state of Minnesota. And we're actually doing things a little bit differently this time. So today we will actually have a pharmacy student kind of give us an intro about the program. And then I will be available at the end for a Q&A, just giving that direct pharmacist experience. So we have Luke Robichaud. I'm hoping I pronounced your name correctly.
Yep. That was perfect.
I can pronounce the drug names, but it's the medicine, the names that get me. All right, so let's get started, and this will be recorded and posted to our YouTube page as well. So Luke, take it away.
All right, so I'll just give a little bit of background on me first. I graduated in 2019 with a biology degree from the University of Minnesota College of Biological Sciences. I'm currently in my second year of pharmacy school at the University of Minnesota. You can see my history of employment there. Used to be a lifeguard, then pharmacy technician, then worked as a tech in inpatient setting, and then I worked at poison control for a little while. So that's about me. And overall, so this is what we're going to go over today regarding the patient certification process. So for example, like how people get diagnosed and how practitioners get certified, and the bureaucracies that control that, and also about what determines a patient's eligibility to, and what types of formulations of cannabis products are available. So for the for the certification process, the diagnosis requires a qualifying condition and by a practitioner who is certified through the Office of Medical Cannabis, which is a Minnesota state office. And the patient receives a link via that Office of Medical Cannabis to fill out basically once they get the qualifying diagnosis, and they fill it out, and it could take about 30 days at most to get approved. Overall, there's the qualifying conditions we'll go over later in a little more detail, but just for reference, there will be, we currently don't have this qualifying condition, but sickle cell disease and chronic motor or vocal tic disorder, those are going to be qualifying conditions as of August 2021 in Minnesota, but they currently aren't. We'll go over the ones that are covered in just a second here. So the physicians, physician assistants, advanced practice registered nurses can certify a patient through the Office of Medical Cannabis if they choose to participate in the medical cannabis program. So it's a voluntary program that the prescriber would have to apply to be able to prescribe medical cannabis, obviously. And then so this link that the patient receives is going to expire if they don't do anything after 90 days. It'll go away. And to register, you need a government issued ID, something like then they accept phone scans of driver's license and things like that, and then some credit and debit card information to pay the annual registration fee, which we'll go into more detail later as well. Registration and rules. There is a $200 annual fee, and it can be reduced to $50 in some circumstances. Those circumstances include being on Medicaid or Minnesota Care, or being at a certain percentage of the poverty line can qualify you for a reduced annual fee. And this does not include the actual cost of the product. So the product itself is another thing that is actually pretty high usually as well. The qualification lasts 1 year. So you got to reapply every year. And there's these products are not going to be covered by any sort of insurance company or the VA or anything like that. It's all got to be paid by the patient themselves, and there's no reciprocity. So if you're coming from another state here, if you have a medical cannabis card from another state, it's not valid here. It has to be only Minnesota residents are able to purchase medical cannabis in the state. The biggest limitation here would be the no raw flower, or just like everything has to be in tinctures, extracts, things like that. There's limitations on the number of companies that are allowed to produce it. So here in Minnesota, we have Leafline, and then Vireo Health, which has been changing names a lot. It's been called MinMed, Minnesota Medical Solutions in the past, but that's still two companies that do all of the cultivating, harvesting, manufacturing, packaging, processing, etc. And they've got 8 distribution facilities, or they're allowed to have up to 8 distribution facilities, and manufacturing and distribution facilities can be housed in the same building. The OMC commissioner determines the geographical service area regions of Minnesota, which are pretty much the same as the 8 congressional districts of Minnesota. And a single company can have no more than 2 distribution facilities located in a single service area. So the ones that currently exist, Leafline operates a dispensary in St. Paul, Eagan, Hibbing, St. Cloud, Wilmer. If you're from Minnesota, you'll know this place, but if not, it might not mean much. And then there's also Minnesota Medical Solutions, or Vireo Health, as they're calling themselves now, operates another 8 dispensaries in Blaine, Bloomington, Burnsville, and Duluth, Hermantown, Minneapolis, Moorhead, Rochester, and Woodbury. And one other little regulation is no dispensary or manufacturing facility can be built within 1,000 feet of an existing public or private school. And in terms of dispensing to patients, the maximum day supply of a medical cannabis product that you can give to a patient is 90 days now. It used to be 30 days. It changed to 90 days in 2019. In terms of hiring limitations, if you want to work at one of these places, you got to be over 21, pass a background check, have no felonies, and every manufacturing company must hire at least 1 licensed Minnesota pharmacist. The pharmacist must be the only employee who can give final approval to dispense the cannabis product, and pharmacists must consult all patients before dispensing the medical cannabis to them. There's the allowed formulations they can be in pills, liquids, topical creams, ointments, gels. Oh,
Sorry.
Sorry about that. Oh no, not this again. Sorry about that.
Okay, cut this out.
All right, my bad. Okay, so apologies there, technical difficulties. And yeah, so all right, we're gonna go on to qualifying conditions. These are kind of self-explanatory here. I mentioned the sickle cell and some other vocal tic disorders that are going to get added later, but at the moment, these are all of the conditions that a physician could prescribe medical cannabis for in Minnesota. All right, so certifying providers, any physician, physician assistant, advanced practice, registered nurses can voluntarily opt in to the program, as I've kind of touched on before. If they're treating a patient within their scope of practice, and they have to be educated or given information on therapeutic use of it, and the providers are given applications. They have applications to give to their patients to apply for the program as well. And then there's actually no public record kept of these practitioners that are participating in the program by the Minnesota Department of Health. So there's no official government record of these providers in the state of Minnesota. All right, available products. So everything except raw flower, as I've said earlier. So there's pills, liquids that can be vaporizable or edible, topical products, water soluble multi-particulate products, which are powders, and then orally dissolvable products like gum, lozenge, sublingual tablets or buccal tablets, but nothing that is combustible, basically. Like you can't smoke, like literally smoke the plant itself. It has to be processed in some way. which is unique to Minnesota, actually, as far as I'm aware. All right. So this program snapshot, I based it on data collected from July 1st, 2015 to December 31st, 2020, and it comes from the Medical Cannabis Patient Registry System. And I can provide a link in the chat later if you'd like, but all right. So as of last year, the end of last year, there were 28,522 actively enrolled patients and 1,831 healthcare practitioners approved in the medical cannabis system in Minnesota. Yeah, we've kind of gone over this mostly so far, but in total, there are 13 total dispensary locations throughout the entire state. Role as a pharmacist. Okay. So the pharmacist is the person who decides the specific dose, the specific formulation, and the cannabinoid profile for each individual qualified medical cannabis patient, which is actually written into the law, and it's a little different. The doctor gives the diagnosis, and then the pharmacist chooses the exact medication. So the role that pharmacists can play in general would be dispensing, consulting, as I've talked before. They also do some third-party quality assurance and testing labs. They can do some lobbying and advocacy on the state and federal level, participate in clinical trial research, regulatory things with the manufacturers and dispensaries themselves, making sure that they're adhering to good manufacturing processes and tracking all their products. You have to have a PharmD in Minnesota, and that's pretty much the only. You have to have at least one pharmacist in every dispensary, basically.
PharmD or RPH, they don't discriminate.
No, I guess.
Active
Okay.
license.
Yep, an active license in Minnesota. Yep. So what else should I say here? I guess there is something that while I was researching possible careers in this field, I found that Leafline actually requires 4 years of pharmacy practice experience, or 1 year of pharmacy practice experience with at least a year of residency. So it might not be something that you could do right after graduating, at least at Leafline. I didn't research at Vireo and Health as much. They didn't have as many job openings, but that could, yeah, that's the most recent information that I've found. And then yeah, the dispensaries will, once you do get employed, they'll give you specific on the job training for how to properly choose cannabis products for patients and drug interactions, things like that. All right, so there's some additional resources here, and now I'll just open up to questions and answers. I think I covered it pretty thoroughly there.
Very good.
Yeah.
Thank you for doing this. So I'll talk a little bit about these resources. So the OMC provides a lot of data. I think that's really what distinguishes Minnesota's program from really any other state, is our robust data collection. So not only do we obtain baseline patient demographics, so not just their age, their weight, things like that, but also their baseline medical conditions, their baseline symptoms. And we're able to kind of track that with each dispense to see how it changes based on the products they've received. Now, of course, there are limitations to any self-report, but all of those reports are basically compiled and then summarized and available for free on the website. So I wish there was more published literature and reviews so that other states can kind of see and learn of what we're doing, because it's very unique. We don't have a pharmacist-led dosing model for many of these conditions, epilepsy, cancer, pain. You don't really have pharmacist involvement beyond simply dispensing. So when you do have a pharmacist in a clinical role providing insight on how to take their medicine, how to adjust it, how to ensure that we're mitigating side effects, it's really interesting to see how patients are benefiting. One of my favorite reports that they actually have is the patient benefit report. And it's like use study or something like that. And it really shows a stark difference between like the patient reported benefit versus the benefits as perceived by prescribers and the qualifying providers. And so it kind of just shows you like we are dealing with symptoms that are not very objectively measured. You know, you're dealing with nausea and vomiting, and you can give it a 0 through 10, but everybody kind of feels it differently. Same thing with pain, super subjective, and that's like the majority of the qualifying patients. PTSD as well. It's not always easy to understand how the patient is feeling their symptoms, and so that kind of makes it a little bit harder to recommend medication therapeutic alternatives. So by seeing like, yes, there are subjective limitations. However, you know, we're still dealing with that person. And even though like, you know, you talked about sickle cell joining the qualifying conditions, Alzheimer's is one of the newest additions. The year before that, we had autism and obstructive sleep apnea. And so you're having these qualifying conditions that have very little to none clinical trial data. So we don't really have robust evidence to support using cannabis in these patients, let alone pharmacist dosing. The other thing, of course, and you kind of touched on it a little bit, Luke, but having pharmacists, or when the patient joins the program, there's a bunch of forms they fill out. And one of them is, of course, to accept and acknowledge that we will be collecting data on them. So it will be part of the public registry. And then the other, of course, is the informed consent. This is experimental, all of it, right? We don't follow FDA approvals when it comes to using these medications. We don't have clinical guidelines to support dosing, whether initial dosing or follow-up recommendations for side effects or condition management. So it really is a novel concept. And so the benefit is that you are able to help that N of 1. So that person that's in front of you, they might not reflect the exact patient population that was in the study that we have, but you can kind of use your background pharmaceutical knowledge and apply those concepts to the medicine, to the patient, and kind of make it work for them. So that's kind of what I like about the medical cannabis program here in Minnesota. But obviously huge limitations, $200 to join. I do believe that's the highest in the country. And they say that's in lieu of taxes. So they don't tax the medicine. And that's kind of, you know, how they can support themselves. These reports cost money. The OMC is staffed by several people and lawyers and all this stuff, and they want to make sure that they can continue to provide for patients. And then I think the only other source of income for them is the manufacturers directly. So yes, there's Leafline, and then I think Vireo changed their name to Green Goods. I don't know if it ends with a Z or an S, but I know it's an alliteration. Do you have any other slides after this one, Luke?
No.
Okay, okay, perfect. Very good. This will look better when we talk. So if you guys have any questions and you don't want to unmute yourself, you can add them to the chat. Otherwise, feel free to unmute yourself. You can have a nice dialogue discussion. I think Minnesota is laxing a bit. I think with Illinois accepting recreational or adult use since I think the beginning of the year now. And then who else do we have? South Dakota. Come on. I don't think any of us really saw that coming because they're quite conservative with their ideals. But, you know, from an adult use perspective, again, not my specialty, but I can definitely see the tax benefit therein. So it'll be interesting to see if Minnesota follows suit. I think the fact that they're arguing to have raw flower in the program is a huge start. Ideally, that'll lower the cost for patients, but, you know, you worry in what did you call it? A biopoly? Never heard that term, but
Duopoly.
Duopoly. There we go. Sounds like a 50s song, like doo-wop, doo-wop. But yeah, that's exactly what it is. And the benefit risk, right? You have these vertically integrated processors. It's very expensive to get off the ground. And it's nice when you work for one of these companies, you know exactly how the products are made, how they're produced, how they're extracted and formulated. So you have a little bit more knowledge as the drug expert. Because it's not like every other pharmaceutical, right? It's not synthesized in the lab, and hopefully no one will find any NMDA in there. like we're finding elsewhere. But it's different. And so being able to have that insight and be like, yes, I've seen what the plants look like. I know how rigorous our protection standards are so that they're not being contaminated, and things like that. It's inspiring to see for plant-based medicine, because if you've worked in pharmacy, you can't really trust those herbal products. And I think that's a huge limitation. That's where our medicine started from. So I don't know if we have any naturopaths on here, but I give love to our herbal remedies. I actually see a lot of Minnesota people here today. Hello, Jeff. I'm gonna call you out.
Hello.
Hi. So do you want to kind of introduce yourself? If you don't want to, it's fine. I can always cut this out. But I know you are a cannabis pharmacist in Minnesota. Do you want to kind of give a little bit of background about yourself, if you don't mind?
Sure. Jeff Shapiro. I'm the dispensing pharmacist up in Hibbing. Been with Leafline almost since they started. It'll be 5 years for me on June 1st. I started in Egan. That was our only dispensary at the time. And then I opened up the Hibbing dispensary on July 1st of 2016 and have been there since.
I love it.
The one thing that I find the most fascinating of this is that I've been a pharmacist for over 40 years now, and this is the most individualized type of medication that I've ever found. You talk about, clinical trials and things like that. Every patient that sits across from you is unique, and what works for one person doesn't necessarily work for another. So the pharmacist, what I like saying is this is doing MTM and then following through and picking out the product as well. So there's only, I believe, 3 or 4 states in the country that require pharmacists. There's no doubt Minnesota is the most restrictive of probably any of the states, which on the one hand definitely hinders some of Minnesota's practices. But I think if we are allowed to go to flower, it's going to open up the program tremendously. There's no doubt having to extract the oil from the plant is the most expensive part of the production. And also there's no doubt that far and away the majority of patients that I've seen over the 5 years I've been doing this, the majority of patients that have dropped out of the program have been due to cost.
Absolutely. It's also tough to see, this is a cash only program. I've heard arguments like, oh, the fact that you have a pharmacist in there is increasing the cost. And I think there could be some truth to that. But in my experience, when you have these complex patients, they can't figure it out on their own. You can send them off with titration instructions, and they might get to the max dose and still not understand what's left for them. Something I kind of want to comment about what you said, just piggybacking. You talked about, having those clinical trials. A lot of our conditions don't have evidence-based dosing information. So we're kind of going by the seat of our tails. But one thing that I like to remind everyone is because of those self-evaluations, that's how the program is able to really grow. And of course, like we have open petitions to allow for new qualifying conditions and new formulations if they're petitioned for. But I think autism, when it was first approved, 2018, I want to say, there were no published trials. So I think there was a study going on in Israel. I don't even know if it's been published, it probably has been at this point. But we didn't have that information. This is just kids with seizures, their parents reported benefit to their autistic symptoms. And that was enough for the state and the overseeing board to be like, yeah, this is a great idea. We don't really have good options. We have like guanfacine and risperidone. So let's just hit them with some antipsychotics. But
Melanie, yeah. It's interesting that you mentioned autism, because when we first started, We actually had some people from the state association or whatever, the practitioners come in and talk to us about how to treat the patients and things like that. And, initially we thought that we would, you're dealing with kids. We found out later that we also are dealing with adults with autism. But we initially thought that we would probably treat them more with CBD than we would with THC, just because of the side effects. And I think what we've learned over the years is that is changed, and that even with the younger patients, and I've seen patients even 5 and younger that respond best to the THC without necessarily getting the side effects of the THC. So autism, I think, was one certifying condition that if somebody had given us predetermined, say, levels to treat them at, that what we actually found in practice is completely different than what we thought to begin with.
Absolutely. I think the same could be said for PTSD. I remember Sue Sisley was doing her study on which chemotype was going to be most effective for PTSD symptoms. So like THC dominant, balanced, or CBD dominant. But it sounds like it will never get published because the quality of the medicine was so poor that it's really hard to compare it to what medical programs have and legal states are able to obtain and share. So it's kind of embarrassing that we don't have that information. And when I think back to my clinical practice with cannabis, it was all over the board. Yeah, we say CBD during the daytime and THC at night, but you always have that person that responds opposite. And I think that fluctuation is what makes cannabis different, but also exciting, because you have someone who couldn't respond well to the other pharmaceutically available products, and now you have more hope in a bottle that hopefully works for them.
Up until within the last year or so, all of the cannabis that was used for research came from, I believe it was the University of Mississippi.
Yeah.
And from what I understand, it wasn't very good. It's only in the last year or so that they started legislation, or the FDA has started, to where they're actually going to use cannabis grown by the individual states. And that in itself, that's one reason why we have such poor data, clinical data to refer to, is because the research has been hindered so much by the product that's available to use for research.
Oh, you're telling me 4% THC isn't a high THC strain?
Not with my patients, it's not.
Well, I do think we're coming a long way, both with like the societal acceptance of cannabis. I don't know if it's because of all the horrors with the opioid industry, but I think a lot of people are kind of being more open to the idea of cannabis. I think it starts with CBD. Unfortunately, I don't think it's the most effective for everyone. But I think people kind of get their feet wet with CBD from hemp, and then they kind of go from there into maybe going into the THC. But like Minnesota's program is very restrictive. A lot of people have to pay the certifying physician to join the program. So there's $200, $250, I've even heard. Some people get lucky and see someone in their network and they could charge it as a typical office fee. But then you still have to do $200 to the state. So right off the bat, you're spending $400 and you haven't even taken any cannabis home. And so just knowing that when people come into the dispensary and they've already spent all that money, I think it really makes pharmacists more cost conscientious. I actually joke that our doctors outside of the cannabis industry, they don't care about costs, because if they did, they'd stop recommending all these brand name prescriptions to my Medicare patients. But it's hard for us to include that in our decision-making process, but it's an absolutely relevant piece. One of the biggest things that we see in regular pharmacy, but not necessarily cannabis, is like continuity of the supply chain. So I think a big concern that we have, at least in Minnesota, is what if we run out of a product that's finally controlled somebody's seizures, or whatever that may be. There's obviously different levels of severity, but being able to provide that trust and credibility in that product source, that's why our manufacturers are so important. I think also like properly allocating products. The plant is like 1% CBD if you're not using like a hemp dominant type strain. So if you have that limitation, you're going to run out of CBD very quickly. And I remember when I first started, there were times where we had like 3 bottles left and we're like, all right, we can't give anyone a full month supply at this point because we will be completely out of it. And you never really want to limit yourself in that regard. Right now, we only have famotidine on the market. And cimetidine, but come on. But even then, it's like, gosh, well, if you tried Pepcid and it didn't work for you, what are we going to do now? And that's like, shoot, and it's like having those limitations. So I think one day we will get to a point where we have this federal ability. I don't know, they're talking about it now, but I'm not holding my breath on that. Okay, are there any other questions from our attendees?
I guess I could add just like something that just happened recently. So a bill passed the Minnesota State Senate committee. So it's going to be for vote on the Senate, and it passed unanimously in the Senate committee to allow for flower in the Minnesota medical cannabis program. So that could be something in the pipeline very soon. That passed as of March 7th of 2021.
I love it. Very nice. All right. Well, if there's no other questions, we will be posting this recording. And then while I have your attention, I think our next one is Oklahoma. Am I right, Eric? Hey, Eric. Hope your presentation's already. Just kidding. I've already seen it. So Oklahoma will be set for May 17th, I think.
Yeah.
And I'm very excited to learn about that because I don't even consider it a medical program. That's how biased I am after being in Minnesota and the role of the pharmacist.
I got you.
Very cool.
I was hoping I could say something.
Oh yeah, absolutely, John.
Hi everybody. My name is John C. I'm not from Minnesota. I know this is about Minnesota. However, I thought, the group might be interested. I'm Canadian. I'm a pharmacist. I'm up in Vancouver, Canada. And as you know, in Canada, we've had medical cannabis for many years. Then we went national with adult use in about 2018. The medical cannabis program in Canada still, it's like you guys, it's pretty asinine, right? I mean, even though there's a medical program, it's outside of the medical system. It's hard to get pharmacists involved. And it's missing so much because when we look at patients, everybody from the cancer patient to pain patients, they could truly benefit from medical cannabis. And Jeff earlier said it's an individual response, and absolutely. But I think from a clinical standpoint, the more we're involved, the better we are to track and bring that to the forefront. And as well as eliminating the stigmatism. Where we can as pharmacists, because people like to come to us. We know the meds, we know the history. I would encourage you guys to more, keep plugging away at it because we are, and we're one thing. Even though you say Minnesota's program is restrictive, I think you guys are advanced in one thing. Pharmacists are allowed to select the product and the dosing. That's phenomenal, guys. It's kudos to you guys because that's where it should sit for the most part. I've been throughout Canada, as well as I've been attending some of the US events as well before pandemic. I remember attending an event down in Pasadena, and some of the physicians were prescribing. They go, well, what did the patient take? I don't know. The patient showed up at the dispensary, and we don't know what they got. Right. So the ability to track it, to trace it, to follow up on it, certificate of analysis, we're still thinking about THC, CBD, but what about the terpenes? What about all the CPGA and THCA and on? We're still learning. And you think about the endocannabinoid system. So the better we as a group that can go on and educate and fight the tough fight, this is a phenomenal sector. And you're absolutely right with your comment about, the homeopathy products or the supplement products that, for the most part, Canada and the US is not too far apart. You know, other than we have a federally, we don't have the issue with the banking. You guys have state and other issues, and
Hey,
but we
I don't mind our credit unions.
but we still are very cautious when we cross the border, right? I mean, prior to the pandemic, some people were getting lifetime bans of even being just an investor in the cannabis sector, not even participating in it. But as pharmacists, I think I encourage you guys, and I want to continue to pay attention to the American market. But we're doing some neat things up here, and if we get a chance to share and show, absolutely, we'll
I'm
love to
waiting
share.
for my Canadian chapter up and running, so feel free to message me on the side.
I'll ping you after.
Love it. And I kind of want to piggyback on some of what you said. So the reason pharmacists are so involved in Minnesota is because doctors from the get-go said, look, we're not taught this in medical school. We have no idea what to do, what's in the pharmacies, what's in the dispensaries. Plus, we don't want to risk our DEA license. So because pharmacists themselves don't have a DEA number, but the pharmacy does, that's kind of how we were able to get around it. So as drug experts, parents were like, we want pharmacists involved here. And I'll never forget, I had patients from the Mayo Clinic, and between us, you know, they were getting themselves certified, their kids certified, but they refused to certify outside people. So like physicians would certify each other type of thing, you know, but they wouldn't really allow publicly to allow for cannabis. So I contacted them. I'm like, well, like, why aren't you guys approving this? Like, you're allowing them to be in their clinical trial, but if they don't meet the clinical trial qualifications, like, this is another option. I mean, if they've tried and failed everything else. And the lady was like, oh, I'll mail you our protocol, like our rules for cannabis. I'm like, that'd be great. Like, I'd love to see what the Mayo Clinic physicians and residents are working with. And I get it. And the very first point is like, we've never had a pharmacist-led dosing model for epilepsy. No, I can't argue with that. And then it was like the next point, like, pharmacists can't order labs, so they don't know what's going on. And I was like, can't argue with that either. Like, I don't know what their carbamazepine level is at. I don't, because we're not viewed as providers, right? So we can't order labs. And then it just kind of reinforced this idea for me that, like, we're all on the same team here. Like, yes, we might be the drug experts and we understand the disease and the drug state interactions a little bit better than other specialties, but I can't do it without that qualifying condition. I can't look at a rash and tell you it's eczema or psoriasis, right? But I can tell you, hey, you know, if this heartburn is lasting more than a week, you should probably get it checked out. Or if it's not responding to your omeprazole or Prilosec, could be an ulcer, you know, things like that. That triage of care, that's what we're taught in pharmacy school. That's how we're able to recommend things over the counter. And my ultimate vision for cannabis, both THC and CBD, is to ultimately see them behind the counter. So we have very good storage and handling and diversion prevention practices in the pharmacy. Why do we treat this any differently? Why do I need to do twice daily counts of cannabis to make sure what we dispensed was correct? We don't do that in the pharmacy. So, you know, having that federal limitation, I think is huge, but I do think we're kind of working towards that, towards a more open model. I don't see the medical program changing in Minnesota anytime soon, but I do think other states are looking to see what we're doing and thinking, okay, what are they doing right? What are they doing wrong? Why is the cost so high? And I think that the fear, of course, is having pharmacist involvement. But I think it's more than that. I think, you know, having a extract only type of state where you don't have the raw flower, it's very expensive. It is, you know, you're extracting it, you're formulating it. If you mess up, you have to restart. You know, you can't reformulate products that have reached the testing lab and they're out of spec. Whether the THC is too high or the ethanol component is still there, you know, so it's like we have to waste all this product. And so my vision is that it can be more of a easily accommodable, that's a term, more accepted medicine. And I think when pharmacists are involved, it has that reduced stigma of, oh, this is a drug of abuse and diversion and things that, you know, can't be controlled. I think there's scarier drugs that I've dispensed in the pharmacy. Yeah. We literally have prescription meth, and that's what, Schedule 3 Digoxin. Your boards are coming up. That was on mine. So, safety is huge, and it really is the safest drug I've ever recommended. However, just the personalization, doctors don't have time for that. Doctors have time for,
Absolutely.
take this, fill it at the pharmacy, see me in 3 months for your blood work. And they don't have time to have that one-on-one, even with telehealth. I think that's great that Minnesota is now offering that. I remember when I first started doing virtual consults, they're like, well, how do we know that you're talking to the patient? I'm like, I mean, I can verify them, like HIPAA, like what else do you want?
Yeah.
What do you want? You want me to get on a video call with a 98-year-old? Okay. So they've definitely loosened up a bit, unfortunately, because of this pandemic. But I think all in the benefit of patients, being able to have a 90-day supply versus a 30-day. You had people driving like 3 hours one way, which is just insane.
Yeah.
So again, treating this more widely acceptable like a medicine, I think we definitely are on the right path. But
No,
I
I think
appreciate your input. Yeah.
absolutely. The more data we can gather to prove that pharmacists can do the job better than others, just because we have the knowledge and the know-how is where we need to go. And like you, we're thinking in Canada we have a lobby group that lobbies the government to change the rules, and completely agree with you that it should be behind the counter in the pharmacy, where we can include it in the profile, and it forms part of their overall care. In Canada we have an area called behind the counter,
Oh
BTC.
yeah.
And
We
in
have it too. It's
BTC,
just very short.
we have what we
Like
call
Sudafed and birth control. That's it.
yeah, no, but we have over-the-counter narcotics, right? We have 8 milligrams of codeine
Yep. Like cough
with
syrup.
acetaminophen and caffeine, right? So in those situations, it used to be basically you counsel and you sell. Now it's gone to a point where you counsel and you sell, but all under the privy of the pharmacist. But you add it to the record. You add it to the patient's prescription record and histories. That way you can follow the patient on a longitudinal basis.
Oh, and actually have liability.
That too, but at the end of the day, like as you say, cannabis is so safe.
Yeah.
But no,
I
thank
appreciate
you
it.
for everybody for giving me a few minutes just to tell you what's happening in Canada.
John, you're always welcome.
Thank you. I got a question in the chat here that was directed towards me. It was about something I mentioned about on-the-job training, and they're asking, Peggy was asking resources to prepare. So Amanda, who's a pharmacist at Leafline, recommended me this book in particular. I guess it's backwards, but Cannabis Pharmacy. It's by like Michael Bax. I haven't finished reading it yet, but it has a lot of really good information, and things that about how to like prescribe it and what the different types of cannabinoids are and everything.
I'll also add on that, the OMC, the Office of Medical Cannabis, see your copy too, Eric. So the OMC provides dosing recommendations. So they provide kind of like a really quick overview of the available literature, both like from the US and the rest of the world. Because obviously we don't have anything like a one-to-one like Sativex or Nabiximols approved. So we do look at other countries where it's approved in 30 others to look to see what they're doing and what their evidence says. So we do have some baseline dosing recommendations, but obviously each person is different and unique, and the pharmacists are instructed to use those self-evaluations that kind of track how they're responding to different products. I remember the first time, it's the same survey for everyone, but if you have like a special qualifying condition like spasms, it'll ask you how many spasms you have, or how many seizures, or how nauseous were you during your last chemo infusion. And the last question is about side effects. And everyone puts in there like, I have no side effects. I haven't taken it yet. I have side effects with my current drugs. That's why I'm here. And it's like, okay, wasn't the question. We can try again later. But like seeing that, it's like there's so much hope when they first start. So having to spend hundreds of dollars can be very disheartening, but we do have some idea of where to start them. I think we've talked about this in our dosing sections before, but like patient preference, patient history, their goals of therapy, their timing of their symptoms, all of this is like determined to help the patient find the best possible dose. I mean, we don't always get it right on the first try. That's why follow-up appointments exist, and whether in person or telehealth. But sometimes we do, and that's great. Sometimes people can figure it out themselves. I had a patient who was 28 and was able to get herself off of her benzo Xanax because she could use a puff or two as she needed it. And it's like, I'm not in that body with her, right? We talked about this for a moment. I remember my first Parkinson's patient, and I kept, it was right around the time that pain became an approved condition. And I probably saw 30 pain patients a day. And so Parkinson's snuck in there, and I was like, yeah, so when you're having pain, this is what you want to like consider. And he's like, I don't have pain. I'm like, oh, what are Parkinson's symptoms? Like, I understand like the gait abnormalities, and I understand like the tremors, but like, why are you here? What are you hoping cannabis will do for you? And like being able to ask that question, I can tell you it's not necessarily something we automatically think of. Put the thing in there, back is actually. So it kind of changes the way we think about things, but very much like MTM focused. I think looking at it from that perspective, treating this just like any other medicine. When I do MTM reviews, I have to look at their over-the-counter, their non-prescription, their herbals. That's technically what CMS mandates for Medicare patients. So why wouldn't I do that if I'm recommending cannabis elsewhere? Looking at that whole patient, considering those alternative therapies that they're using, instead of just ignoring them. Even when I do reviews now, they'll call me back and be like, okay, I didn't want to tell you this, but I'm on medical marijuana. I'm like, all right, what are you taking? And just taking that stigma. I think they're so scared of what a pharmacist will say that they're not even honest with themselves sometimes. Or worse, they're doctors. I think that fear that we had this one journal club about anesthesia requirements in chronic cannabis users. And that's like a huge fear for people, like waking up on the operating table and, feeling something, or just having the anxiety of that. Need a benzo just for that. Need some CBD, right? Cool. Well, we have just a couple more minutes if anybody else has any final thoughts. Mary Jo, it's good to see you.
Melanie, hi, my name is Rich Oborn. I work with the State of Utah Center for Medical Cannabis, and there was a pharmacist that recommended I join and listen in, and I've just been listening in, and thank you for sharing some information. One question I had is how common is it that as a pharmacist you would recommend that a patient use multiple forms of cannabis, a tincture and a capsule, or a tablet, or a lotion, right? They're getting multiple forms their first time in order to find which one of those work best for their type of condition. Is that pretty common in Minnesota as you practice there?
Absolutely. And another thing that we collect that data, I think there's a report called Dosages and Compositions, but I think it only actually shows it for chronic pain or intractable pain at the time. But you can kind of see like the formulations work differently, right? If something is quick acting, it's going to wear off quicker. And so you're going to need something, either dose that more frequently or provide a more longer acting formulation. So I'd say for the conditions that we treat in Minnesota, we absolutely need a balance of both. Something for like maintenance. And that also kind of, in my opinion, helps keep the cost down. So instead of taking, 2 puffs every 4 hours, if you can build up a baseline level with pills or liquid or something else that has a profile of 8 to 12 hours, some people 24, I think that also helps bring the cost down, but just got to be careful with side effects. I think other cannabis pharmacists can say, but I felt much more comfortable with the vaporization. It wasn't smoke. We don't have smoke here. But just being able to control it. If you have people that are very anxious about trying cannabis, you take a puff, you're going to feel it within 5 minutes and you'll know right away what is the effect. People always ask me, is it like drinking? I'm like, I don't know. How do you feel when you drink? Like people all have their unique responses. So just kind of helping ease the anxiety. And we live in a culture that wants relief now. So if you take your Vicodin, it'll work in 35 to 40 minutes. It is literally time to dissolve in that amount of time. Whereas cannabis doesn't have that luxury. It depends on the food in your stomach, the other medicines you take, your gut anatomy in general. So we don't have that same easy to follow profile that we can just apply for every single person. So when we do have the option to allow for different sites of absorption, that allows for different dosing parameters. So maybe a pill would be every 6 to 12 hours. A puff would be every 2 to 6 hours. You kind of give the patient more control. More challenging for a patient that cannot self-medicate. So looking at like autism and those that are in like a group home setting or nursing home, assisted living, whatever, not being able to kind of medicate as needed makes it more challenging. And so like those, we wouldn't really recommend those, but overall, I think the percentage was like 85%. But again, you know, time and place. In my perfect world, we'd be preventing pain, not treating it. So just looking at it from that perspective, I don't want people chasing their pain with a puff from their vaporizer. I'd rather nip it in the bud.
That makes sense. Thank you.
Yeah, absolutely. All right, everyone. Thank you so much. This will be posted to our YouTube channel. If you don't follow us already, please subscribe. And then next month is Oklahoma. Looking at you, Eric. I'm saying that we're going to stay in the Midwest. I call it the mild West because I think whatever's going on the Pacific and the Atlantic coast is just nuts right now with all this legal stuff and lack of pharmacist involvement. So yes. See you guys next time. Thank you so much. And I hope you all stay safe.